Hi, everyone, and welcome to another episode of From Print to Pod. I'm here with Dr. Stephen Cohen, who's a board certified general and colorectal surgeon. I'm going to let him introduce himself in just a second and just tell you that he recently wrote a piece on the three A's of surgical training: availability, affability, and ability. And I'm going to actually let him introduce himself before we dive into the questions that I have ready for him. So, welcome.
Thank you so much. My name is Stephen Cohen. I am board certified in both general and colon and rectal surgery, now on year 31 in practice. I have been in the private sector. I currently am involved in teaching, training, and educating both medical students and residents on how to become and what the best way to become a surgeon is for long-term success.
Okay, fantastic. And I will also add a plug in here that you're involved in, which is that you are going to be a speaker at our upcoming finance, investing, and real estate conference that's online. So I'm really excited about your talk. We won't get into that here, but we will get into the questions we have about your article and beyond. So let's start with the basics. What inspired you to write about the three A's of surgical training?
Well, one of the things that surgical trainees don't get, and even back when I trained 30 years ago, it's how to become a surgeon. And I know that sounds silly, but I say this all the time. We only teach you the basics of surgery. It's indications for surgery, it's disease process for surgery, it's different options in surgery. And I tell the residents this all the time. You learn to become a surgeon in practice when you're by yourself, it's midnight, and there's nobody else around to ask you. It's like learning to drive. I can't do it for you. And there's a lot of spoon feeding that goes on in surgical training because that's the way it is. It's not good or bad, but it's very important that they understand that the way that we're looked at in practice is very different as a resident. There's a lot of people around, but when you're by yourself, it's those three things in that order that make or break a surgical career.
Thank you for that. And was there a specific moment or experience that sparked this?
Yeah, so early in my career, again, nobody told me this. They just taught me the basics. I felt like I could operate after being a resident for 7 years. And then you get thrown into practice. And the availability piece of it is, as a resident, and you know this as well as I do, when you get a consultation from your medical doctors, you don't really want to do it, right? It's like you try to get out of work, but that's not the case in practice. You want the work. So not being available in a timely fashion, which is very quick, because when the cardiologist calls you or the internal medicine doctor calls you about an acute abdomen, they're not waiting, right? And they're not waiting. And if you don't respond in a timely fashion, right off the bat, you're getting a bad reputation and they're calling somebody else. So your reputation, even in any interaction, forget surgery, when you meet somebody, within 90 seconds, they've already made a judgment about you. Does he look at me in the eye? Does he shake my hand? You get that vibe right away. It's no different when you're interacting in a collegial management, with your colleagues. So being available is the most important thing. And it's silly, but you don't have to be the best surgeon ever, right? It doesn't, but that's not what they're looking at. It's availability is number one to build your career.
Well, you also appear to be a mind reader because my next question was going to be, of the three, availability, affability, and ability, which do you think that residents struggle with the most and why? Actually, it's not. You answered which is maybe the most important, but which do you think that residents struggle with the most?
See, I think the residents look at it backwards. They say ability should be, they have to be the best surgeon. And if they're mean to the nurses, they're mean to the junior residents, that doesn't matter. That does matter, right? It's how you treat people. And if you're not, the middle, they think of ability and then they think affability and then availability as being last, but it doesn't work like that. In practice, it doesn't work. Um, they have so they have to look at it backwards, right? They're going to get the basics of how to operate. Taking out an appendix, doing a right colectomy, they're going to get that. But it's your interactions with people that others will see, they will judge you on that. It's how you get along with the family. Are you nice to the nurses? Do you walk down the hall and see dirt or paper wrappers on the ground? Do you bend down and pick that up? It's what kind of person you are is how they will judge you as a practitioner.
Now, in your own training or practice, was there a mentor or colleague who really embodied all three A's?
Yeah, absolutely. I mean, in my colorectal fellowship, the those attendings really had it all together. And they had been doing this for years. I mean, I trained at the Cleveland Clinic in Fort Lauderdale. This was back in the 90s, but that program was brand new back since 1988. So the seasoned attendings from the Cleveland Clinic mothership were sent down to start this program. They had to be like that. I mean, again, it's a long story, but the Cleveland Clinic, when it sent out to be down there in South Florida, the community didn't want them there. They didn't want them there. It was known that healthcare in South Florida wasn't that good, but this is an area, Fort Lauderdale, Miami, that served 6 million people, and being available, being nice to people. I mean, it really changed the culture of medicine in South Florida because of the Cleveland Clinic. And they all did it just right. And I learned from them. And they didn't let things wait, nice to everybody. And it's the little things. And I tell the residents this all the time. In private practice, every Sunday when I was rounding at my hospital, I'd stop by Krispy Kreme's, get those 12 dozen donuts, and they love that, right? It's the little things like that. Individuals, whether it's patients, whether it's employees, whether it's nurses, they want to feel valued. And if they don't feel valued, they don't feel like you care, even though we do care, but you need to make them feel like that.
I couldn't agree more. All right, let's go to the next question. Affability can be a tricky one. It's not something we're usually graded on. How do you think we can teach or model that effectively in a surgical environment?
And that's a difficult one because a lot of it takes some emotional intelligence. Knowing what's going on around you, knowing how you're perceived. Certainly, I ask the residents, or I tell them, if they're in a situation, if they're operating, get some feedback. Get some feedback from your attendings. Get some feedback from the nurses. Go talk to the head nurse on the floor. Is there anything I can do better? How can I improve? Is there any issue with my communication? Because remember, the electronic medical record has changed everything. So they can sit in their office, put all the orders in. I didn't train like that. I don't understand that. I would have to go to the floor, find the nurse of my patient. How is he or she doing? Is there anything I can do today? Is there anything you're concerned about? That was the norm back in the 80s. That's not the norm today. So I encourage them to face, talk to the people that are at the bedside, and that will go a long way.
Thank you for that. So, with the current focus on work-life balance and wellness, how do we reconcile that with the old school idea of availability being 24/7?
Yeah, and that's a challenge, but certainly there are ways to do it. Most physicians nowadays, even in surgery, have partners. They are employed. It's good communication and good handoff. And I'll tell you one of the things that I used to do in practice, and I had to learn this the hard way. I wasn't on every weekend. We had a group of 9 doctors, 7 offices, 50 employees. Doctors are allowed to have some time off. That's okay. But if I didn't tell my patient who was in the hospital on Friday that I was not rounding, they would be mad at me on Monday. You didn't tell me you weren't coming in, and I took it for granted. So after hearing that a few times, the light bulb went on. So on Friday afternoon, post-op day 3, right colectomy, they weren't ready to go home yet. I'm not going to be here this weekend. Dr. So and so is going to be rounding on you. He knows all about you. I've told them the operation you had, why we did it. I told him that today your NG tube is still in, you haven't passed gas. He knows what to do. I trust him to take care of you. If there's any question, he has my cell phone. So it's communication. Once I did that, no issue at all.
Very important. Now, have you seen a shift in how different generations of surgeons interpret or prioritize the three A's?
Yeah, I think the availability, that's why I wrote this article because, with the, way back 20 years ago with the 80-hour work week, with the night shift call principle. Remember, when I was a surgery resident, there was no extra person coming in at night to take call. There was three of us usually on the rotation. We did our 24-hour shift every third night. It's a different system now, right? So now these kids, the way the system is, they sign out at 6 o'clock in the evening. There's a whole separate rotation where all you do is work nights. So the availability piece gets lost. That's why I think this is an important article. Whether you're in academics, whether you go into private practice, communication with the patient, proper handoff. So the individual physician colleague taking over for your patients knows how to get a hold of you. It's a very difficult system because the night shift person comes in, they may be taking care of 30 patients in the hospital. That's a challenge. I don't know what operation, I don't know what medications the patient on. Why did you keep the Foley catheter in? There's so many moving parts. Communication is important, proper handoff, and setting expectations for the patient who bonds with you as the provider. Don't leave them hanging.
Thank you for that. If you could sneak in a fourth A into this list, what would it be and how would it complement the others?
Yeah, that's a great question. There's a bunch of other A's. I would say that the fourth one that's as important, and we alluded to it a little bit, is accountability. You have to take responsibility for your patients. Remember, they walk into the door with a problem that you are going to solve with a surgical operation. They don't want anybody else. So be accountability is very important in everything you do. If you order a lab test, you are responsible for following up on that result. Don't leave it to somebody. Of course, with good sign out, with good handoff, that's okay. But don't assume somebody else is going to pick up the slack. Be accountable. You order a white count in the morning, it is your responsibility to check on the result. That's what the patient expects. That's what I would expect if I'm the patient. If you're going to order a CAT scan, why are you doing it? Is it going to change the management of your patient? Follow up with that. Accountability is very important. Don't assume somebody else is going to fill in the gap for you.
Fantastic. Some incredible pieces of advice shared there. Is there anything that you want to leave our audience with as we close up this episode?
I hope you enjoy the article. I think that surgical training specifically has changed in the last 30 years, some of it for the better. Certainly, I'm not the one that says that I did it the hard way, so it has to be done that way. Not at all. And I think articles like this and websites and communication that you've created are very helpful for the younger generation, and leaning into some of their mentors to help them will be much better for them in the future.